Hi. So in this video, I'm going to be talking about the heart and how it depolarizes, how it contracts, and how it sends signals electrically. So first, starting with depolarization, we can go in and look at how exactly each specific area depolarizes. So this depolarization wave right here is the SA node, but also normal skeletal muscle. So the SA node depolarization differs from the other connective tissue in the heart. So the normal SA node, it's just like the SA node, it depolarizes kind of the same as skeletal muscle would. You've got the sodium channels opening and then closing once they reach the threshold, and then you've got the potassium channels opening and then closing, just like that. It's normal. But then when you come to the connective tissue of the heart, it has calcium as well as potassium and sodium. And the calcium is really big in the heart. Calcium helps with contraction. So the more calcium, the more contraction. So in the connective tissue, you've got the sodium channels opening, coming up just like how it would here, but now you introduce the calcium, and the calcium causes a delay. And the calcium delay allows for the heart to, instead of it, and I'll go more into detail later, instead of it all contracting all at once like that, it allows for a delay for it to all squeeze and then squeeze back up. So you need this calcium delay so your whole heart isn't just contracting. And then you've got, once the delay is over, you have your potassium channels opening. So it's connective tissue, you add in the calcium. So cells in your heart are going to look different from the cells in your normal skeletal muscle. And this is because your heart cells have these things called intercalated discs. So imagine you have like a cell and another cell. You've got this thing right in the middle of it, kind of like that. Okay, I'm not an artist. But you have your two muscle cells, and then you have your intercalated disc. And the intercalated discs allow for electrical signals to travel from one cell to the other. So this is how electricity is going to travel through the heart. So let's say here's my electrical current and it's going like this. Instead of it just stopping in this cell, this intercalated disc acts as like a bridge to the other cell. So it allows for the electrical current to pass through and travel to the next cell. And normal muscle cells don't have the intercalated discs, so that's what makes the two fairly different, is because the heart cells have intercalated discs. Okay, so we've got the signal traveling through the intercalated discs and all the cells, but the actual pathway of electricity through the heart is this. Okay, so we've got our heart, our potato heart. Your heart, it's split into all four of its quadrants. All right, so here we have our heart. You've got your right atrium, right ventricle, left ventricle. So how the electrical signal actually travels through the heart. It has multiple different pieces. Gotta get all my different colors. All right, so we're gonna start with our first place where electrical currents are gonna start. It's gonna start at your SA node. Oh my goodness. It's gonna start at your SA node, which is up here in your right atrium. It's about right here. So there's your SA node. This is your pacemaker of the heart. This is gonna set your exact timing of your heart. So your electricity, or your brain is gonna send a signal through your SNS, your sympathetic nervous system, and it's gonna be like, hey, yo, SNS, or hey, yo, SA node, I need you to start. So your SA node is gonna be like, all right, we have to start sending electricity through the heart. So what it's gonna do is your SA node is gonna spread its signal all the way across your atrium, like this. All right, so you've got your current being sent all the way across your atrium. And the reason I only drew it like this is because there's a layer, I'll do this. There's a layer of electrically dead cells right here. So remember when I was talking about that calcium leak a little bit ago? This is where your calcium leak starts to come into play. So you've got your layer of electrically dead cells. And then your next thing is called your AV node. You got your AV node right there. So your AV node will collect the signal from the SA node. And then your AV node, it'll wait a minute. This is your AV nodal delay. So this allows, your AV nodal delay allows for your atrium to contract, but it causes your ventricles to pause for a minute. So after your AV node receives the signal, it's gonna stop at your bundle of His, which is right under it right here. So it's gonna send it to your bundle of His, which is also your bundle branches, like this. And so now your signal is gonna be sent down the septum of the heart, which is the middle of the heart, down your septum of your heart. So now your ventricles are starting to depolarize. So once it's being sent down, apologies, then it's going to go from your bundle branches to your Purkinje fibers. And your Purkinje fibers kind of like hug your heart from how they are. They kind of just spread out like this, just everywhere. All right, just like that. So going all over this again, you have your SA node is your thing that gets the signal first. So you've got your SA node, and it's going to be like, let's send out our signal. Sends it across your atrium. Then your AV node senses this signal, and it's like, all right, we got to work too. So then your layer of electrically dead cells stops this signal from coming down here. Your AV node then sends a signal down the septum and up the ventricles. So this allows for your heart, instead of it all going like that, blood's not going to pump very well through that. It needs to go down, up. So you've got this atrium squeezing into the ventricles, ventricles squeezing up, your right sending blood to your lungs, and your left sending blood to the rest of your body. This can also be seen through a EKG. So you've got all right, so this can also be seen through an EKG. This is how you can see depolarization of the heart, but on like a screen whenever you're at the doctor. So you've got your P wave, your QRS complex, and your T wave. So your P wave represents your atrium, both of your atriums, your atrium depolarizing. So you've got your P wave, boom, first step, atrium's depolarizing. You have your QRS, which is your signal being sent through your ventricles and back up. So this is where it's being sent through your bundle branches, and this is your Purkinje fibers depolarizing. And also your, and then you've got your atriums repolarizing also in here. And then your T wave is your ventricles repolarizing. So this is just a way you can see how depolarization is happening in the heart in a graph, like from the doctor. So now that you see how the electrical signals are sent, the electrical signal doesn't mean anything unless you actually look at the contractile unit of a heart muscle cell. So the contractile unit of the muscle cell, or the heart muscle cell, is called a sarcomere. And the sarcomere is where the contraction really happens. So we've got our little goldfish guy. All right, So this is your sarcomere. So you've got this. This is called your T-tubule. We're looking at this from a transverse view. So it's like the cell was cut this way. So you've got your T-tubule, which electrical signal is being sent this way. Okay, so you have your T-tubule. From there, you've got your voltage gate feet, or the little voltage feet guys, like this. Boop. These are your voltage feet. They're going to collect the calcium being sent down the T-tubule. This is also the calcium in the depolarization that I drew earlier. So you've got the calcium being sent down the T-tubule, boom, calcium feet catch it. So then it's going to send the calcium into the SR, sarcoplasmic reticulum. Then the sarcoplasmic reticulum, it's going to release that calcium. Swoop, swoop, calcium. And it's going to be caught by your sarcomere. What color? Let's do green. Okay, here we go. You've got your actin and myosin and your titin. Your titin are these guys. They're strong, okay? They're gonna pull. It's gonna be like they're gonna yank on the rope. They're like your bungee cords. That's a good way to describe it. So you've got your actin, which is this guy right here. Actin. And you've got your myosin, which are these little fellas. Good Lord, they're just doing so much yard work today. All right, so you've got your myosin. All right, I'll try that much. All right, so you got your actin and you have your myosin. So your myosin heads are going to grab on to actin, but this can only happen with these different types of troponin. So your actin and myosin are going to connect. The myosin heads are gonna grab onto the actin, but that can only happen if you have the troponin moving out of the way. So there's 3 different types of troponin. You have troponin T, you have troponin I, and you have troponin T. So what's going to happen is you have troponin I, and troponin I is blocking the myosin from being able to grab the actin. So what you have to do is, so you've got, see how these are touching? So you've got the troponin I, your inhibitor, blocking the myosin from grabbing onto the actin. So what happens is the way that becomes unlocked is when troponin C grabs the calcium. So calcium is the key for this. So your troponin C is going to grab onto the calcium. Once troponin C grabs onto the calcium, troponin C tells troponin I, hey, you can move out the way, so it unlocks it. So then when troponin I moves out the way, it scooches over. Then it allows, so you have troponin C connecting to troponin I. My hands are troponin I. When troponin C tells troponin I, hey, you can open, it goes like this, and then the myosin can grab onto actin and pull on it. And then troponin T, he just kind of sits there. He binds to tropomyosin. And tropomyosin is the thing that kind of just like sits there. Like it's just this little thing that everything sits on. So yeah, that's how the sarcomeres work and where the actual contraction happens. So going back to the depolarization things that I drew at the very beginning, that calcium is going to be sent through here. It's going to be sensed by the voltage feet. It's going to tell the sarcoplasmic reticulum to release calcium. that calcium is going to be sensed by troponin C to then tell troponin I. It can move out of the way so that troponin I moves out of the way so that myosin heads can grab onto actin, and it can pull and cause contraction to happen. When that happens, that pull, it generates ATP or inorganic phosphates, and it has to then bind with more ATP so that it can let go. And then you can have another pull. One thing I forgot to mention. There's this thing called phospholambin. Phospholambin and SERCA. They kind of just like sit on the sarcoplasmic reticulum, the SR. They just kind of sit here. That's gonna be the SERCA. And this little guy, that's phospholambin. All right, so when the sarcoplasmic reticulum releases calcium, sometimes some cells may not have a lot of calcium, or they'll over send out the amount of calcium it needs to. So let's say our cells sends out too much calcium. Our SERCA is like our vacuum. It's going to vacuum up those calciums that are just kind of hanging out in here. So once those get vacuumed up, then that allows for less calcium to be binded with troponin I or troponin C. So let's say our cell needs more calcium. It's not getting enough. You've got our little guy over here, phospholambin. He turns off SERCA. He turns off the vacuum and allows for more calcium to be binded with troponin C so that more contractions can occur. Okay, so the next thing that I'm going to talk about is heart failure. And with heart failure, there are two different types. So there's basically two categories. You've got HFrEF, and you got HFpEF. They sound really similar, but they're two very different things. So HFrEF and HFpEF. Okay. All right. HFrEF. Sound like Scooby-Doo. HFrEF is the more bad. It's the worst one. So HFrEF deals with systolic, and HFpEF deals with diastolic. I'm just going to abbreviate. Okay, so HFrEF is heart failure with reduced ejection fraction. So what that means is the heart is having trouble ejecting the blood. So with HFrEF, you've got blood sitting in your left ventricle because there was some sort of signal mishap with the electrical signals and the excitation coupling, that it won't allow for the left ventricle to eject the blood out of the heart. So with that happening, you don't have really good heart contractions. So what the heart's going to try and do is some of the ways that it will try and fix this, which only leads to worse things, is because your heart is having trouble ejecting. It's like, hey, let me help you out and give you some more sarcomeres, the thing that I just drew, give you some more sarcomeres, and then you'll be able to pump more. Wrong. So what it's gonna do is, you've got your sarcomeres, okay? It's gonna go like this. These are your sarcomeres. It's gonna take all these sarcomeres and it's gonna put them all together and it's gonna say, now you're so strong. No, because now what's happened is, instead of having a lumen like this, you've got a lumen like this, too big. The heart has now, the left ventricle has now become flaccid. And it's like you've taken a rubber band, Or like a ponytail holder. You've taken a ponytail holder and you've tied it around your hair so many times that it's so loose, it doesn't hold your hair well, like at all. It's the same thing that's happening to your heart. You've made it and stretched it and stretched it and stretched it and stretched it so much that it just can't pump very well anymore. And then this leads to even more heart failure. So this one is really bad. You don't want this one. This one decreases your stroke volume and raises your preload, which that goes into your cardiac output equation. These two things, heart rate and stroke volume, are what keep your cardiac output being how much blood can be pumped to your body that your heart can do. You've got your stroke volume, which is separated into preload, afterload, and contractility. So you've got your preload and it's rising. You've got so much preload because preload goes with the amount of stretch, the rubber band being stretched too many times. You're rising your preload so much, it's gonna cause a decrease in your stroke volume. You would think it wouldn't, but yeah. Your stroke volume is gonna go down because your preload is so high that it just can't pump enough blood. So HFrEF is no. That's a no. We don't want HFrEF. And your heart makes it worse by trying to fix it. So now HFpEF. HFpEF is the one you can live with. HFpEF, that's okay. You can live with HFpEF, that's fine. HFpEF is heart failure with preserved ejection fraction. So with this one, your ventricle isn't filling properly. So with HFrEF, it was an ejection issue. HFpEF is a filling issue. So with this, you have decreased ventricular compliance, which means it's too hard to stretch. So it's like you've taken your rubber band and you've stuck it in the freezer. It's not gonna stretch very well, like at all. So you can't even pull on it. So less compliance, less stretch. That means you also have impaired lusitropy. Lusitropy means relaxation. So your heart rate is increasing because you've got blood not filling. So you, instead of like, let's say this is your ventricle, okay? Or here's your heart. Here's your ventricle, your left ventricle. Let's say it's only allowed to fill to like here. And that's your blood. When usually it should be able to fill to like here, all the way. It should be full all the way. So your heart is basically going to increase your heart rate because it's like, this is all we get. So let's just throw it all out as quickly as we can to get the normal amount of blood that we normally want around the body as quickly as we can. So you have lusitropy, meaning relaxation. So your heart isn't allowed to relax as often because your heart rate is increasing so that it can send what amount of blood it has in it out. Okay. Last thing we're going to talk about is the different types of imaging that can be done on the heart to see if you're going into heart failure or if you have coronary artery disease, something like that. So the first one is an MRI. All right, an MRI. So I don't know if you've had an MRI before, but basically what it is this big tube, okay? Here's the table, and this is a transverse view of it. So you're looking at it dead on. So you've got the person's head, and then their feet are like, boom. I'm not an artist again. So, geez, that looks like an ant. Hang on. We're just gonna say that's the person's head, okay? So you get sent down this really big tube, and what this does, this MRI, it allows you to see your soft tissue, meaning muscles or ligaments or tendons, anything like that. No bones. Bones are for x-rays. So you're gonna be sent down in this tube, It's gonna make a lot of loud noises. Those loud noises are actually sound waves being sent to disrupt your atoms. So before you go in this MRI, this is what you look like. All of your atoms are kind of just like balling, just doing whatever they want, like this. This is outside the MRI. All right, so this is what you look like outside the MRI. As soon as you slide in the MRI, it hasn't even started, okay? You haven't even started your imaging. As soon as that happens, all of your molecules or atoms, boom, same way. You're gonna look like this, okay? This is inside. All right, here's inside the MRI. Once that happens, you got those loud, like, ka-clunk, ka-clunk noises. Super annoying, but that's okay. When that happens, I'm just gonna do one. All right, so here's one. You've got your sound wave, which is that really big clunking noise. It's going to send a sound wave like doo-doo-doo-doo-doo-doo. Boom, smacks into it. And it's gonna cause your molecule or your pole of the atom to go like this, and it's gonna move. So it's gonna go like that. Okay. So now, instead of it being like this, it's down here, like that. And what the MRI is going to measure is how long it takes to click back into place the way it's supposed to be facing. And what this does is how it measures how it takes an image of different soft tissue regions, is each soft tissue region has its own specific amount of time that it takes to swing back to its right direction. So that's how it can tell the difference between like ligaments, tendons, muscles, bones, things like that. So that's how you get the images of MRIs. And with an MRI, this one, you can do an MRI however many times you want, because it deals with no radiation or anything like that, so it can be done frequently. And this allows for you to see like any muscle issues. So like for our example of HFrEF, where we have an issue with like our muscle becoming too flaccid and too big, you can see that in an MRI compared to like what a normal left ventricle should look like. You can see like it completely different and not looking how it's supposed to be from an MRI. So you can see if someone's going into heart failure. With the other one, there's another one. There's a bunch actually. So that's an MRI. Next, I'll kind of explain this one. So it's a PET scan, but I'm going to explain it as a part of a nuclear stress test, because a nuclear stress test is just a PET scan of the heart. Okay, so your nuclear stress test. So what's going to happen is your patient is going to come in and you're going to inject them with a half-life molecule, radiation, and it's gonna, this scan that you're gonna have them do, it's going to be able to trace the photons from the radiation. So PET scans are usually used in people with cancer, but the nuclear stress tests are used to see how perfusion in the heart is working. So what you're gonna have someone do is your patient's gonna come and they're gonna be like, or you're gonna have them be injected with the radiation, and at rest, when their heart is at rest, they're gonna go through the scan. And what's gonna happen is they're gonna do the same thing. You've got your big tube that they're gonna slide in, okay? But instead of this instead of this getting an image of your soft tissue, it's not really tracing, it's not gonna like measure, it's not gonna show an image of anatomy. It's gonna show where the tracer, it's gonna trace the radiation through the heart. So you inject them while they're at rest. And inside of here, they've got their photons, which is the radiation. So you've got your photon. And it's going to, so it's got all of these cameras all around here. And the photon, as soon as it releases, it's like radiation. It's gonna come out like that. Always comes out at 180 degrees. So it's releasing its radiation like this. So then you've got your cameras, like here. I should have done a square. Cameras. So these two cameras are at 180 degrees. They catch this photon being, like, emitting its radiation. So it's gonna catch it. And then what it can do is it can trace where that is right in the middle and see exactly where that molecule is. So that's happening inside the tube that the person is in. And what's really good is this is really good for the heart. Because let's say someone has like coronary artery disease. So their arteries are blocked. You can see exactly where that blockage is. So you can see it at rest. Or when it's time for you to do your second injection. And you do your second injection under stress. So they've gotten their first injection at rest, sat in the tube. They're done. Then you're gonna put them on some sort of exercise testing test, put their heart under stress to increase their heart rate. Usually it'll be like on a treadmill with an incline. And you'll have them do that. And then as soon as they're done with that, you inject them and you throw them back in the tube. And you're gonna do the same thing, except maybe their heart, like you have a full ring like that of your ventricle. And it's like, cool, that's normal. It should look like that. And this is at rest. Let's say you put them under stress. And that's how the normal one should be. Let's say they're like missing, like that. They've got portions missing. That means something's wrong. There's something wrong with your ventricle. So they could deal with poor perfusion, or your ventricle couldn't be filling properly, or your artery couldn't be filling properly. So you've got a blockage somewhere. And it's good to do it under stress because, yeah, it's all fine and dandy to look at something while you're at rest. But let's say you've got a patient who has to like walk really far to work, or they have to climb a bunch of flights of stairs. And their heart looks like that just after climbing some stairs. Something's wrong. So you got to get them checked out, like for real. So let's say you have a person who can't fit in the tube. What you're going to do is, no, scratch that, delete that part, Lily. So let's say you have a person who can't exercise. They can't do the treadmill test. There are drugs you can inject someone with to increase their heart rate, and that will basically replicate if someone was to go under stress. So here's your nuclear stress test with your PET scan in it as well. Okay, last one is an echocardiogram. I'm just gonna write echo. Echo. Okay, this is your echo. So an echo kind of sounds like echolocation, like how a dolphin or a bat would use. It deals with sound waves. And what an echo does is it does an ultrasound of the heart with a transducer. The transducer is the thing that like the physician holds. And it's gonna send sound waves to the heart. So here's your heart. So here's your heart. And the sound waves are gonna come down like this. There's your sound waves. And what the transducer catches, here's a transducer. That's about what a transducer looks like. So it's gonna send your signals at the heart, okay? What the transducer measures is how well the sound wave is reflected back. So just like how bats use echolocation to see and how dolphins will use echolocation too. It bounces off and then comes right back. And this is what the transducer is catching. The transducer catches the reflection of the sound wave. And what happens is if it needs to go in like one of the ventricles or something, the sound wave can travel through the blood. Come on. Through the blood, and let's say it's like passing through the blood, boom, hits the ventricle. It'll come right back. So this helps also get an image of the heart as well, kind of like an MRI, but this is like a handheld one, if you want to think of it that way. So this also deals with soft tissue and things like that, so you can also get a picture of what the heart is looking like. So yep, that is depolarization, muscle contraction through the heart muscle, how electrical signals are sent through the heart, and how you exert force, and also 2 different types of heart failure, and different types of imaging, and what exactly they can find. Thanks for watching.